Today we have Dr. Nishi Garg, who will be talking on difficult situations in cesarean section. She has more than 32 years of experience in obs and gynae. She is a member of IUFMB and IME. She is the secretary of WTW Faridkot. She is member of Family Welfare Committee and member of Violence Against Doctors Committee. So, welcome Dr. Nishi.
Thank you for kind introduction. So first of all, I would like to thank Vlogs and especially the organizing team for inviting me and giving me chance to stand here to speak on an interesting topic of anticipate that everything will go well, especially in a normal cases. But sometimes the same case turns into a difficult scenario and gives us a lot of palpitations. So my talk is here, there are many scenarios which we... So this will help to plan and examine the patient before even giving anesthesia, do a per abdomen examination and auscultate the fetal heart again on the operating table. So now in all cases we do this, that we take the patient in the left rendicular position, but especially in difficult cesareans because the operating time is going to be more. So we always see that patient is having slight tilt to prevent the pressure on the inferior vena cava so that fetal blood supply is going on. Already talked, mainly we are doing in phalansteal incision or lower abdominal transverse incision, but in rare cases like if it is a case of big fibroid on the lower segment or placenta ingrata syndrome, we may have to go with a vertical incision which you can enlarge to any size. So when we are opening the abdomen, first scenario is like the case of previous cesarean, 1 cesarean, 2 cesarean. Nowadays the number of cesareans is increasing and we are getting cases of previous 3 cesareans also which are pregnant and at term now. So adequate excision of the surgical scar is important. So we make an elliptical incision and we remove the scar tissue so that we are able to stitch it better. And if muscles are tight, we have to cut it. And special care when we are entering the abdominal cavity, especially in repeat cesareans, because chances of gut adhesion, this we are doing in repeat 3 or 4 cesareans. So change the uterine incision rather than spending time on opening the bladder. And always check the integrity after doing the surgery. So this is first scenario. So then closure also becomes difficult. Sometimes you don't get even peritoneum to stitch it, or even the uterus lower segment is so, upper segment is thick and lower segment is thin. So when you take a stitch, it gives way from the lower segment. So just be patient, don't give a pull on the upper side, give a pull little on the lower side and you will not get that tear. And sometimes if there is a hole, you can stitch it separately with a catgut. So good. So now scenario 2. This is a free floating head. There is nothing. It becomes very tricky when you try to pull the baby. The head slips. Fundal pressure given. It again goes laterally and you are not able to hold the head. So in this case, a very important tip is you just give a small leak in the lower segment. Just wait for a minute. The lighter will drain. The head will come and will get applied to the scar area, the incision area, and then enlarge it with fingers and give a good exposure. You will be able to take out the baby. And if need be, you can use vacuum, you can use forceps, or even single blade of forceps can be used. Now third scenario is impacted fetal head. These type of cases were earlier seen more, and when we were working, I was working in medical college. At that time, these type of cases used to present. So we deliver the baby in this by 3 methods. One is push method, one is pull method, and one is breech extraction. Push method, then the next scenario is premature, but there is less tear with Vardhan technique and it's very safe for baby as well as mother. So this is the fourth scenario in which there is extremely low birth. I just touched few important points on every scenario. So this is the extremely low birth with baby. In this, the most important thing we face is very less it is ruled out, then we take up for cesarean at 37-38 weeks and tie the bleeders, if at all they are present, on the lower segment beforehand before giving a cut on the uterus. And after incision, either we go through transplacental side or we insinuate our fingers between the placenta and uterine wall and try to take out the baby. And if need be, even we sometimes have to apply forceps also on that. So then the most difficult surgery nowadays scenario is placenta ingrata syndrome. We have done few cases in medical college on PAS. So here the incision, both abdominal and uterine, it matters. Midline vertical, uterine incision should be away from placenta, and preferably we plan hysterectomy. So we do classical cesarean. Along with that, we leave placenta in situ and we go ahead with hysterectomy afterwards. So they have to go in for hysterectomy later on. So another scenario is percarita. So in this case, we as gynecologists should take multidisciplinary approach along with urologists, because sometimes you may have to end up. So then next scenario is lower segment fibroid. These are also increasing, and I have done many cases with fibroid with pregnancy. So first, if you have ultrasound available in OT, just see where is the fibroid present and take an incision above the fibroid. But sometimes this mass comes in the line of the surgery. So this is a one just along the line. This is the fibroid I am removing. Can you play the video? Hello? Next video, can you play? This was a fibroid just over the stitch line. So ideally, fibroid should not be moved while you are doing surgery, but once it comes on your stitch line or it is lying subserous, you can take a chance of doing a myomectomy in such cases. This was the bed which I am closing. Let's stop the video. So, and usually when you are doing this fibroid, if it is a very big intramural fibroid, ideally we should not touch. But otherwise, you can remove it with the advent of cautery and other drugs. You can do it. So then next scenario is an obese patient. Also, this is on increase nowadays. Getting a patient of 110 kg, 120 kg. So when I did my first cesarean of a 120 kg patient, I was really afraid. So there is difficult anesthesia, airway, poor exposure is there in such cases. Pre-operative, we should have senior obstetrician. And skin and abdominal entry is same. Pen steel is preferred in this because vertical there will be more chances of hernia. So lower segment transverse incision is done. Wound closure will be difficult. Most important is we should always close a subcutaneous. Call for help. Don't hesitate in calling your seniors or your friends. Whenever you find there is a problem, always ring a bell and call so that your moral boost is there, plus you get a double help to save the mother. Teamwork saves lives. Meticulous surgeries and vigilant post-op care reduces morbidity. And a safe cesarean is not just delivery of the baby, but safe completion of the. Difficult cesarean sections need teamwork, successful management, requires coordination between obstetrician, anesthetist, neonatologist and nursing staff. Most cesareans are not surprises. Difficult cesareans are not surprises, they are failures of anticipation. So, anticipate and anticipate before every surgery. Thank you very much.